Hello everyone, and welcome to our webinar entitled HPA-Axis Dysfunction in Obesity. Our guest speaker today is Melanie Dorion. My name is Michael Chapman, and I'm a medical education specialist at Genova's Asheville branch, and I'm going to serve as moderator for today's webinar. We would like to welcome Melanie Dorion. Melanie is a nurse practitioner, founder, and CEO of Pentad Integrative Health. She also practices at Downtown Family Healthcare in Charlottesville, Virginia, focusing on fatigue, Lyme disease, weight management, and gastrointestinal health. Her approach is grounded in nursing, functional, strategic, and naturopathic medicine philosophies. She studied naturopathic medicine at Bastyr University in Washington before doing her nurse practitioner degree at Seattle University. She's a member of the Obesity Medicine Association and the Institute for Functional Medicine and has received advanced training in obesity management, nutrition, exercise science, and methylation genetics. Her speaking engagements include Genova Diagnostics, A4M, and is a regular speaker at Mary Baldwin University, in addition to leading health workshops in Virginia. One of our most common questions we get asked during the webinars is about availability of this presentation and the slide deck. These materials will be available on our website within a week of the webinar. And so if you're interested in having these resources, please click under the Clinicians tab on the homepage of our website, where you'll find access to our webinars under Medical Education, or you can also log into your MyGDX account to find these webinars. If you do not have a MyGDX account, please click on the Getting Started link in our homepage. And now I'm going to turn it over to Melanie. And again, thank you for being here.
Hey, Michael.
Hi. I can see your screen great.
All right. We're good?
Yeah, we're good.
Great. Thank you, everyone, for attending. So we're going to dive into HPA-Axis and cortisol dysfunction and obesity. And this is a topic that fascinates me because probably about a quarter of my practice is weight management. And I've seen a lot of dysfunction in the HPA-Axis and cortisol results, and a lot of unexpected results from both urinary and salivary testing. So this was a great opportunity for me to dive into this topic and really try and understand what's going on and look at some of the studies. So as we discussed, we're going to go over the HPA-Axis dysfunction and obesity, but I really want to take a couple minutes as well to review some of the contributing factors in weight gain and obesity, and then discuss the dysfunction that is happening in HPA-Axis and cortisol metabolism. And then we're going to talk about management and therapeutic options for our patients. When it comes to weight gain and obesity, it's really, really important to understand that it's really a multifactorial problem. This is not as simple as eat less and exercise more. Because if this would work, if this was the solution to the obesity crisis that's happening worldwide, we would have been a lot more successful by this point at achieving successful and maintaining weight loss in our obese and overweight patients. So we gotta look at all the factors that lead to obesity and weight gain. Of course, we always start with diet and lifestyle. We know that's a big component, but that's not where we should end the conversation with our patients. And of course, here highlighted is the hormonal influences, and there are many. But today we're going to look at the cortisol and the HPA axis, of course. But I want you guys to not forget as well that a lot of the obese population are significantly nutritionally deficient. And vitamin D, omega-3, fatty acids. I see a lot of B vitamin deficiencies in the obese individuals. So don't forget that when you're treating your obese patients. And then there's immune and gut dysbiosis that is happening. There's the gut dysbiosis area is an exploding area of study for diabetes and obesity. And right now the links or the correlations are not clear as to exactly what's going on, but we see a lot of gut issues in our obese patients, and some studies are looking at stool transplants and helping patients to successfully reverse diabetes, lose weight, and then maintain weight loss after stool transplants, which is a fascinating area. And then there's, of course, genetics and epigenetics. But, you know, when I talk to my patients and they say, well, this is genetic, and you've probably all heard that in your obese patients, it's genetic, my family has it, and, you know, I'm the leaner of my family members and BMI of 35, but genetics are only part of our loaded health gun. And this is how I explain genetics to my patients, is that we all have a loaded health gun of some sort. Genetics is part of that. But really what pulls the trigger is the epigenetic factor. Epigenetics, so the epigenetic factors, diet and lifestyle, toxins, and emotional factors. So what really causes or triggers disease is really the environment. So it's not so much the genetics. So it's not your genes that are making you fat. It's really important for us to discuss with our patients. And it also removes a little bit of pressure and gives them back responsibility that you're not doomed because of your genes, and your genetic heritage from your family does not doom you to be overweight or obese. So there's a lot that we can do about that. And of course, another factor is neurobehavioral. So now switching to the hormonal component and really diving into the HPA axis, into the cortisol dysfunction that's happening in obesity, there's been a lot of studies. When I started diving into this topic, there's no shortage of studies looking at this topic. But what I found was that there is a lot of conflicting results. And some were showing, for example, greater ACTH responses. So when you do the dexamethasone or the ACTH responses to suppression tests, greater responses in some studies and not in others. And some studies were showing different levels of circulating cortisol. So there isn't consistency in the results when they measured circulating levels of cortisol. And then some studies were looking at morning cortisol specifically, and then low morning cortisol, but high urinary cortisol output in overall after 24 hours. So there's a lot of conflicting results. And if you start looking into this, you'll agree that it's confusing. And some of these explanations that why we can explain some of the differences in these results, we're looking at a lot of these studies were actually pretty small in sample sizes. So 15, 20, 24, 30 participants. Multiple of them had single gender or single ethnicity. And then the other thing was that there was some pretty tissue-specific alteration or changes in cortisol metabolism, which I'm going to dive into this quite a bit because that probably explains most of the differences in the results that we can see in the studies. And when you think about it, cortisol metabolism, if it's tissue-specific, well, that means doing a biopsy. That's just not practical. Let's be honest, and very few participants are going to agree to this invasive procedure. So there's limited studies showing that, but the studies that I did find that really clarified the tissue-specific changes in cortisol metabolism were actually well-done studies that clearly showed what was going on in the tissues. So I'm going to go into that here in a little bit. And really what's happening is some of the consistent patterns is that greater abdominal fat, so abdominal obesity, visceral fat in the abdomen, greater BMI, greater waist circumference does seem overall to be associated with just a more highly responsive HPA axis. So a little bit of a tendency to be more in the sympathetic mode. And then the other pattern that is consistent is that there's an upregulation of cortisol output in adipocytes. So fat cells in obese individuals seem to have a different metabolism than non-obese individuals. So we're looking at actually a greater activity and a greater expression. They looked at the genetic expression of this enzyme, the 11-beta-hydroxysteroid dehydrogenase enzyme. And yes, I did have to practice the name of this enzyme because I've just been calling it the HSD1 for a long time. So yes, I practiced. But the HSD1, and I will refer to it as the HSD1, the HSD1 enzyme is overly expressed or increased in its expression, and it's more active in fat cells than it is in liver cells or in hepatic tissue in obese individuals. So the HSD1 enzyme converts cortisone to cortisol. And what we found was that this led to an increase in cortisone metabolite, so the THE1, which we can measure in urinary testing, which is great. And just remember that the cortisol metabolites are THF, and the cortisone metabolites are THE. So that's important to remember later on because I'm going to refer to these. And as I mentioned, the HSD1 enzyme is downregulated in hepatic tissue, which we're suspecting is why we have found some different levels in plasma cortisol in many of these studies. So it doesn't seem to be so much central that the HPA axis is dysfunctional starting in the brain, but there's more a local tissue changes in cortisol metabolism, which actually explains a lot when you look at the studies and probably what you've seen in some of your results. And this is a great review that was published in 2012 by Lucassen and Sissa, and they looked, this is a review, so they looked at multiple studies and looking at the relationship between stress and HPA axis, sleep, and obesity. So they looked at multiple different relationships. When focusing specifically on the HPA axis in relation to obesity, they found, and they came up with this on the right here, the diagram that actually shows this really well, the tissue-specific changes in regulation of the HSD1. So if you look at the bottom right, on the right-hand side with the diagram, the bottom right shows fatty tissue, so adipocytes, and the increase in activity in the HSD1 leading to a greater conversion of cortisone into cortisol, therefore an increase in the THE1. But they also found, after looking at multiple studies, that THF also, so the cortisol metabolite. So overall, in the relationship between the HPA axis and in obese patients, they found that urinary levels of THF and THE were increased in obese subjects. And they found that, similar to multiple other studies, that the cortisol, overall cortisol in serum, so representing overall cortisol secretion, was actually normal, but the metabolites were upregulated. So, what's the take home of looking at this study? It really highlights the increased activity of the HSD1 in the fatty tissues and the decreased HSD1 activity in liver tissue. And then looking at the increased THE, so the cortisol metabolites, so you're looking at an increased catabolism or breakdown of the cortisone. And they've also found that the hyper-responsive HPA axis was really highlighted in obese individuals and not as highlighted in lean or normal weight individuals. And this was shown in multiple different studies by the dexamethasone, so this is depression test that is done. Usually it's endocrinologists who will do the test, and these studies were looking at the responses to these testing. And then overall, hyperactive sympathetic nervous system, especially in patients with central obesity. And they also looked at what the outcome was after weight loss, and weight loss did lead to a normalizing of the HSD1 activity, so a decrease in HSD1 activity in the obese individuals, which is really important to understand, because when I get to the management in just a little bit, how can we help even before weight loss? Because yes, of course, the goal is to help our patients lose weight, but can we do things before weight loss occurs? So can we help set our patients up for success even before weight loss? What can we do to decrease the HSD1 activity in the fatty tissues? So we're going to talk about that in just a little bit. This is another study that was extremely well done. It was a really significant study. This is the MESA study, which is a multi-ethnic study of atherosclerosis. They looked at over 1,000 patients, and over 3 days, on average, each patient did on average 18 salivary cortisol samples. So this was salivary, so it wasn't urinary, but overall, the outcome really solidifies some of the things that I've been discussing and highlights some of the other findings that we found in other studies. And overall, the higher BMI, higher waist circumference, they were associated with neuroendocrine dysregulation of multiple different forms. And they did find dysregulation in salivary cortisol. And what they found and this is after controlling for multiple different variables, that for the entire cohort, when you had a higher BMI, higher waist circumference, the area under the curve, so when you think about the salivary cortisol, this is multiple salivary cortisol over a day in a 24-hour period. So it gives you the diurnal curve that obese individuals had a lower curve. So it was negatively associated. So higher BMI, higher waist circumference led, the pattern we were seeing is a lower morning cortisol and overall a lower area under the curve of the diurnal salivary cortisol. So the big take-home picture here is that there is neuroendocrine dysregulation. So this study, they also found that specifically in participants with diabetes, which is a significant proportion of the obese, overweight and obese population, that the cortisol curve was suggestive in HPA axis hyperactivity. And then the other really interesting thing, especially for me, because again, I do a lot of obesity management and weight management, and I deal with a lot of elevated A1Cs, and even without diabetic level A1Cs, prediabetes also is consistent with this pattern that the increase in the positive correlation between the BMI and the waist circumference, we found that the A1C was highly predictive of the dysfunction in cortisol secretion and overall diurnal changes in diurnal salivary cortisol. So this study, I really encourage people, I encourage you guys to go look at this study, the MESA study, because again, it's over 1,000 participants, which is a lot of people, and multiple different ethnic backgrounds, males and females. So that's probably the biggest study with the most variables, looking at multiple different variables, really that represents overall in the population what's happening. So this is actually a great study that, again, was published in 2013. Now we're going to transition a little bit to look at other causes of HPA-Axis dysfunction in obesity specifically. So chronic stress, and again, the study earlier from Lucassen and Sissa looked at specifically chronic stress and with sleep issues. But overall chronic stress, either physical or emotional, seems to lead to HPA-Axis dysfunction, especially when it becomes chronic. Obviously, some acute stress can be positive, but when that stress becomes chronic, it can lead to hyperactivity, and hyperactivity will lead to higher cortisol and therefore contribute to weight gain. So I tell my patients that if they're in this chronic stress state, so my obese patients or my weight management patient, if they're in this chronically stressed state, they're going to be in a higher cortisol state, which means when cortisol is circulating, often, so cortisol goes and talks to the liver, and the liver is going to respond often by putting out glucose into the blood. And when this physiological state is happening, weight loss is extremely challenging. So having high levels of cortisol, high levels of sugar, and therefore also high levels of insulin, the patient is going to have a really hard time losing weight. The body is not going to be able to access, this is just basic physiology, is not going to be able to access fat stores if insulin levels are high or the glucose levels in the blood are elevated. So this is important to have this discussion with your patients, what the impact is and what the physiology is. And I pretty much tell them, I say, listen, if you eat a lot of carbs, a lot of sugar, or you're chronically stressed and your sugars are high in your blood, you're not going to be able to access your fat stores. To be able to burn through the sugar in your blood and then subsequently some of the glycogen to access fat stores, people need an extreme amount of exercise, and some studies have reported something like 3 hours of vigorous mountain biking, which most of our obese patients are not going to be able to do that. So it's just not realistic to try and achieve weight loss via exercise in a state of chronic stress. So we've got to work on the stress and the elevated cortisol levels from stress in our patients. And the other topic that I'm extremely passionate about when it comes to obese patients or weight gain is sleep disorders. And I've seen this myth in so many patients at this point that I do a screening for sleep disorders in every single one of my patients. Because of course we know that obesity is linked to sleep issues and potentially obstructive sleep apnea. But just remember also that the sleep problems can contribute to the weight gain. You know, it is chicken or the egg thing. So what is starting what? Well, we're actually really not sure in some cases. And I've seen multiple cases of patients who have reported that when they've noticed or their spouse noticed that they were starting to have sleep issues is when they started gaining weight. And they weren't obese at that point. They were maybe slightly overweight, but not obese. But after that, the weight gain really accelerated. And it was difficult for these patients to stop the weight gain in order to start losing weight without restricting calories and aggressively exercising, which is just not sustainable. When you look at sustainable models of weight management, exercising 3 hours a day with caloric restriction is absolutely, one, not healthy, but it's not realistic for our patients. So looking at this, please don't miss sleep disorders, because sleep disorders will contribute to high cortisol and HPA-Axis dysfunction. And when you think about obstructive sleep apnea, there's some estimates out there that are saying that about 45% of obese subjects have sleep apnea. That's about 18 million Americans. That's a lot of people. And if we are not screening for them, I assure you that a lot of primary care, these people, even at their annual, are not asked a lot of these questions. Basic question of, do you snore? How sleepy are you during the day? Or how do you feel when you wake up? Has your spouse reported any changes in your sleep? You know, a lot of these patients are never asked these questions, and they're going to be in your office, and I assure you that you're going to have some overweight and obese individuals that have never been screened for sleep apnea. And then also remember that poor sleep and sleep deprivation is going to decrease glucose tolerance, decrease leptin, and then increases cortisol, and also increases appetite. So sleep apnea is incredibly important. I've seen really good success with better weight management, but also glucose management. So my patients with diabetes or prediabetes getting much better glucose control after finally being diagnosed and managed properly and using their CPAP, and just integrating better sleep hygiene overall and sleep habits. One of the other cause of HPA-Axis dysfunction is inflammation. And most of our obese patients actually are inflamed. We're seeing a lot of elevated interleukin-6, for example. And why I picked that one specifically is that we do have support that interleukin-6 will upregulate HSD1 further. So you already have an upregulation of HSD1 in fatty tissues when our patients are obese. Then you add the further increase in HSD1 expression. So really vicious cycle here that starts happening in our overweight, obese, and inflamed patients. And then mood disorders and low caloric diet, the low calorie diet. This is one of those that I really, really zealously dislike. I really don't see that has done any good for any of my patients. It's a very popular thing. It happens all the time. And also people have been told, or obese patients have been told, well, just eat less, without being given clear parameters about what that means. I'm going to talk a little bit more about the low calorie piece, but also please don't forget thyroid disorders. Of course, weight gain can be a contributing factor to obesity and HPA-Axis dysfunction. And when we look at low calorie dieting, and I wanted to put this study in here. And this is a study that looked at, it was a smaller study, so 121 female, so it wasn't male and female, but it was still overall a good study, because I have found similar results in other studies. But overall, low calorie dieting. So these 120 women were put in one of 4 different groups. And the group that had to do monitoring of their calories and do low calories had actually increase in cortisol and had higher perceived stress. So bottom line, restricting calories, bad. If one of the things you remember from today is that doing a low-calorie diet, and the low-calorie diet in this study was 1,200 calories, and that's fairly low for most active women. But when you think about some of the diets that are out there, some diets are restricting calories even further, looking at below 1,000, so 500 and 1,000 calorie diets. I've seen many of those patients, and they're going to be in your office not too long after doing that, with potentially a very dysregulated hormonal system. Overall, long-term effects of low-calorie dieting is that patients can often become leptin resistant, and in addition to HPA-Axis dysfunction. So we are the ones picking up the mess when it comes to patients who've done multiple or have done long-term low-calorie diets. So please educate your patients, try and prevent this from happening, because reversing the disaster that happens from low-calorie diets, reversing that is actually very, very challenging. Often I have to use at the beginning weight loss medications to help these patients, because we're just not very good yet in medicine at understanding how to undo some of the hormonal imbalances and some of the hormonal damage that happen with low-calorie dieting. And the effects of even just a 3 to 4 week low-calorie diet can last for months for some people. So this has long-term consequences. So low-calorie dieting, bad. And then when I mentioned the thyroid earlier, the relationship is real, and we often forget this, but this is a great diagram that I actually pull up often when I talk to my patients who have HPA-Axis dysfunction. And when I talk to them about their thyroid, and if they already have thyroid dysfunction, I show them then the link with the adrenals, that this is interrelated, and the dotted lines are the inhibitory pathways. So when you look on the left-hand side at the bottom, the cortisol pathway will have an inhibitory mechanism, or an inhibitory impact on TSH, but really on T3. And this is something that I see a lot, actually, or frequently, I should say frequently in my obese patients, is that T3 is downregulated, so they have suboptimal levels of T3, and they may have elevated levels of reverse T3. So at the bottom right, on the right-hand side of this diagram, you see reverse T3. This is something that's really, really important to remember, that please measure reverse T3 in all of your patients, especially your patients who are overweight and obese, or if they've done low-calorie diets, because I often expect reverse T3 to be elevated, and in multiple of my patients, we found elevated reverse T3, and I had to work backwards. So patient comes to me for a thyroid issue, and they're overweight, but they're not necessarily a weight management patient, and I find a elevated reverse T3, and then I go back, and often I've redone histories and found that they did a lot of yo-yo dieting, and they were currently in a fairly low calorie state. So almost, not quite starvation, but almost starvation mode for the body. And the body kind of panics, increased cortisol, and then kind of blocks the pathway by which the T4 conversion to T3 is done. And therefore the T4 is going to be sent somewhere, and it's sent to reverse T3. And I can actually manage or monitor caloric intake for some of my patients by looking at reverse T3. And it can be that sensitive, monitoring reverse T3 for some patients. The other thing that I've seen cause elevated reverse T3, and there's multiple different causes, and I'm going to go into that in a few slides, but I do want to highlight it right now, is that also anemia or low iron, even without anemia, so low iron, so a ferritin often below 40 or 50 is really considered suboptimal level of ferritin or suboptimal level of iron storage, can cause elevated reverse T3. So please don't forget the relationship between the adrenals and the HPA axis and the thyroid, because you're going to see some dysfunction. And some of these factors that affect thyroid is some of my red arrows, I apologize for that, shifted a little bit in the conversion, but the small red arrow here was supposed to highlight stress, and the big arrow was supposed to be moved left a little bit and highlight the low calorie diet. And this is a great diagram from the Institute for Functional Medicine that shows thyroid physiology, and that the low calories is going to push that reaction towards reverse T3. And remember that reverse T3 and T3, they dock in the same receptor. So if reverse T3 is high, it doesn't matter how optimal the T3 level is, the patient is not going to feel the benefits of that optimal level of T3 if reverse T3 is high. So you have to implement strategies to decrease reverse T3s, which in our medicine, we got to look at the factors. So you look at the bottom left, area here, that list. So stress, trauma, low calorie diet, and toxins. That's a big one nowadays, and infection. So when you think about chronic or lingering infections, think EBV, so Epstein-Barr, mono, Lyme disease. I've seen multiple different patients with elevated reverse T3 that had Lyme disease. So when it comes to testing, and this is a really important topic because there's multiple ways to test for HPA axis and cortisol levels and DHEA levels and all that. But it's not always clear where to start. And I want to remind you guys of this lovely pathway that we all love that is so well done here. And I've put red stars to highlight the pathway of cortisol to cortisone and vice versa that highlights the HSD1. Well, it's really that cortisone converted to cortisol is done by the HSD1 enzyme, and then HSD2 converts cortisol into cortisone. So this pathway is highlighted here, and if you look, if all else fails, bring out this pathway and read what's in the boxes because, well, it's right. And when you look at more cortisol, the things that impact this HSD1, so remember where the red stars are here at the bottom, the obesity, especially visceral fat, metabolic syndrome, so insulin resistance, hypothyroid, so all these things that I've been talking about will impact the HSD1 enzyme and change slightly that physiology in obese individuals. So just remember your pathway. And then what test do I order? Do I order saliva, serum, urine? So this is a great table that was done by Dr. Larson and colleagues, and it was published in 2014 in the Townsend Letter, and it's still available. If you go to their website, townsendletter.com, you can still pull that up and look at all the things that are measured. And this was a great way for me when I started. Thankfully, I had access to this. It's a great way to start to know what do you want to measure and what's the best way of measuring it. So there's multiple different ways of measuring the HPA axis and hormones. And my preference is actually 24-hour urine testing for HPA axis and cortisol because, well, now we know there's going to be a dysfunction that's not necessarily central, so not necessarily coming from the brain, but that's going to be more local. And the only way to really assess that is looking at the metabolites. So I like to start with the 24-hour urine test so I can see all the metabolites and see where the dysfunction is happening. And what I often do is then I monitor with salivary testing to see what the curve looks like and what the general pattern is. But different people have different views. A lot of people are still using, to begin with, the salivary testing with a lot of success. Simply my clinical experience, I lean towards a 24-hour urine, but it's not as convenient to do a 24-hour urine test or 24-hour urine collection versus a salivary. But there's a lot of advantages I found to doing, especially at the beginning, a 24-hour urine to look at the metabolites, because that's really the only reliable way of looking at the cortisol and cortisone metabolites. And then if you look at the bottom right, you look at all of the hormones that you can see with the 24-hour urine. You're going to also see aldosterone, which in our chronically fatigued, obese, and overweight patients, often there's going to be a dysfunction in aldosterone secretion, and our really exhausted patients often suffer from low blood pressure, and you start seeing aldosterone dysfunction or other hormone hormone dysfunction that we don't measure in salivary testing. So again, the 24-hour urine panel, and when it comes to Genova, it doesn't automatically come with cortisol levels. So always add on the cortisol measurement so you get a full, complete picture. So that's a really important reminder, because I've forgotten on many a times and had to contact my rep to get that added on quickly. But it's important to always add on cortisol so you have a full picture. So just remember that. Remember this, that Genova's 24-hour panel does not automatically come with cortisol levels. So you have, that's an add-on. So it's going to be a little extra cost for your patients, but it's totally worth it. I think the information we get from that full picture is valuable. And it measures unbound forms of hormones. So again, like I mentioned, you're going to also see the metabolites. So if you look at the bottom here, we look at the THF, the 2-THF from the cortisol, and the THC from cortisone. And remember that cortisone to cortisol is the HSD1. And then when cortisone is broken down, you're going to see the THC metabolites. And also the 24-hour looks at the full picture, and it's not likely to miss high or low values, or it's not likely to miss areas of dysfunction, which I've seen in salivary cortisol, where I really expect my patients to have an abnormal cortisol HPA-Axis dysfunction, and I measured salivary cortisol. In a few cases, I found that salivary results were normal, but the 24-hour cortisol levels showed abnormal secretion of cortisol, and especially the cortisol and cortisone metabolites. And then also remember that if you look on the left-hand side, that orange box, you're going to look at the mineralocorticoids, which, if that is dysfunctional, you're looking at a really chronic HPA-Axis dysfunction. So this has been happening for a long time, months to years in some of our patients. And then the salivary testing, so that is very convenient. It's 4 salivary samples over a 24-hour period. It's a little bit easier to do, and it measures the free hormones, and it gives you the curve and DHEA. The curve is really pertinent when you're monitoring treatment as well, and when you're looking at overall patterns. And I have a great case that I'm going to present in just a little bit that discusses that. So, this is a redundant slide. I apologize, but the little egg here with the chick is totally worth repeating this slide, because, like I mentioned earlier, is it the chicken or the egg when it comes to sleep disorders? But I'm going to focus a little bit more right now on sleep disorders and mood disorders, because the diurnal salivary curve is associated with elevated body mass index and waist circumference, as I mentioned earlier. And screening and testing for sleep and mood disorders. The Epworth Sleepiness Scale, I do this on all of my patients who come, all my new patients. So this is part of my screening that I do, and I do it on all patients, obese, non-obese. I screen everybody for this. With this scale, I've actually caught 2 cases of narcolepsy. So this is an important screening to do, and this is not tired or fatigued patients. This is to screen for sleepiness. So you look at obstructive sleep apnea, narcolepsy, restless leg syndrome, and it's pretty well validated. I collaborate with a fantastic sleep specialist in town who's really educated me on this screening. And pretty much, if I'm going to refer someone to him, he wants me to do this screening on my patients. So I encourage you. It's free, available. You can find this PDF online at multiple different sites. So it's an easy thing for you to print. Just have your patients do it even before you walk into the room, and then go over the results with them. How sleepy are they? Anything above a 10, 12, they're pretty sleepy, and you got to consider sleep apnea. And then when it comes to mood disorders, I do a PHQ-2 and then subsequently a PHQ-9 if it's warranted. But don't remember that mood issues is also going to cause some HPA-Axis dysfunction. There's really good studies out there showing the relationship between mood, insulin resistance, HPA-Axis dysfunction. So this is for real. Don't miss this. And a lot of your patients, if you don't ask them, they're not going to tell you how truly emotionally they feel, or how poorly managed their depression or anxiety or bipolar are. So please screen your patients, be thorough, ask them how they're feeling. Then just a little reminder about thyroid testing. These are my optimal levels. I like a TSH at or below 2.5 and free T3 above 1.3, a free T4 above 1.3, free T3 above 3.0. Some people like a little bit higher than that, but I'm getting good results with trying to aim for free T3 at or above 3.0. And then I like a reverse T3 under 20. And as I mentioned earlier, just remember that reverse T3 has the same receptor as free T3. And you see elevated reverse T3 in mitochondrial dysfunction, which is very common in chronic infections, Lyme, also fibromyalgia, diabetes, insulin resistance. Reverse T3 is also going to be high in elevated cortisol. And then I've seen clear patterns with selenium and iron deficiencies, as I mentioned earlier. So switching to management now, our patients are often tired and wired. So what do we do with our obese, tired, wired, stressed out patients? Well, as we should with all of our patients, please start with diet and lifestyle. Now, when it comes to obesity, what does that exactly mean to do changes in your diet or dietary recommendations? And this is what I use. I have a handout that goes over this that I give to my weight management patients. These are based on different studies that I've looked and different guidelines. The Obesity Medicine Association has a lot of guidelines on this, but I usually have my patients either do carb conscious, low carb, or ketogenic diets. If the A1C is elevated, depending on how elevated it is, I'm going to go right away for low carb. If they're super game, if they're ready to go, I'm going to go ketogenic. Which, if you're not familiar with the ketogenic diet, it's a very low carb. It's about 65–70% fat, 25% is protein, and very low carb, so 5% carb intake. And then go over net carbs with your patients, which is total carbs minus the fiber. So please read the food label with your patients and teach them how to read this. And just a reminder that I've done LiveGDX in August 24th last year of 2016. So August 24th, I did a LiveGDX that went over management, so a lot more depth in management for obese individuals. So this information is also in there, and there's a little bit more stuff. So if you guys want more about management, there is another LiveGDX that you can go see. It's online. It's still up, so you can look at the PowerPoint or listen to it. But there's more about management. This is just a really quick overview here, but it's important still to go over this. Again, lifestyle, sleep. Sleep is really important. So improve their sleep quality. It's not just about quantity. Sleep quality is important. You can refer to sleep specialists if they score high on the Epworth. And then, of course, encourage your patients to move and exercise. But it's not training for a marathon. It's moving your body. You know what, guys? Gardening counts. Going up the stairs at work counts. So talk about this with your patients. And then mindfulness, deep breathing, and being exposed to daylight is really, really helpful when it comes to resetting sleep. And then more specifically for tired and wired, I utilize quite a bit of phosphatidylserine in my patients. The Cortisol Manager by Integrative Therapeutics is a great supplement that really helps reset sleep and helps our patient get calmer and get better sleep. I'll use homeopathics, I'll use GABA, magnesium, P5P. Those are all really good tools to help our patients who are tired and wired or having issues with sleep. And I want to put a little plug for Alessandro Ferretti, who is a gentleman who's really leading the trend in measuring different parameters and looking at what parameters can we measure and can we encourage our patients to measure that really leads to better health outcomes. And he's a big believer in HRV, which is heart rate variability. And right now he's studying in depth, and he's just come out with really amazing data looking at the HRV and glucose. So I encourage you guys to go to his website. He has great information, lots of free videos on there. But these are things that patients can easily do, measure their heart rate variability, which you want high variability. So you want good highs in heart rate and you want good lows. And then things like heart math and meditation and CBT are really, really helpful in the mind-body area to help our patients be more successful with weight loss and a better outcome in their cortisol secretion. And when it comes to botanical support, absolutely adaptogens. They're great support for a lot of our patients. Just a little warning and highlight that I've seen this happen many a times, that some patients who tend to have anxiety may not tolerate the Luthro or the Siberian ginseng. So I tend to avoid it now completely early on in my patients who have current or recent anxiety. So I tend to go with more grounding, centering, like oats, avena, ashwagandha, rhodiola. But otherwise, if your patients don't tend to have anxiety and they're overweight, obese, they're super depleted, really exhausted, Panax and the Luthro are fantastic. And then people who tend to have a lot of stress that they carry in their shoulders, don't forget about wood betony or stackies. That's a great tool that's often underutilized. And then when it comes specifically to HSD1 inhibitors, well, you know what? We have a ton of really good studies looking at licorice, turmeric, and green tea. So green tea extracts potentially, don't use those long-term though, but short-term of these nutraceuticals have really good impact on decreasing the overactive HSD1. So you're looking at HSD1 inhibitors. There's some studies going on out there with specific extracts of these nutraceuticals, but why not just use licorice, turmeric, and green tea as a whole? So really encourage you to integrate some of these in your therapeutic options in your patients. And salicylate, that's the other one that actually I found was that salicylate was acting actually as an HSD1 inhibitor, which is fantastic news. And then insulin resistance, please don't forget about this because 51% of older adults have insulin resistance. Most of them do not know it. And then insulin will promote lipogenesis and prevent lipolysis. So it's really hard for patients to burn fat. And these are therapeutic options that I use when it comes to specifically addressing insulin resistance. So my first case is a 70-year-old female. She was presenting for weight management and fatigue, and she had multiple years of debilitating fatigue. She had been diagnosed with Lyme disease and obstructive sleep apnea, low ferritin, and she wasn't morbidly obese, but she was at a BMI of 30, but she was now starting to see a clear pattern of pretty constant weight gain. So these are the things that I ordered for her to try and explain some of what's going on with the weight gain. And this is her 24-hour urine, the complete hormone that I did on her. And when you look at the cortisol is normal. And this explains, this represents what some of the things that I talked about earlier. And as expected now, because we know that there's fat cell dysfunction in HSD1, we see higher metabolites. But when I did this, wow, this was about 1.5 years ago, I didn't have this depth of knowledge and I was pretty baffled by this, but now I understand why. So this is just a great example of what you're expected to find in your obese and overweight individuals when it comes to the complete hormone. So we did a bunch of stuff with her, but we definitely started a low carb diet, got her off of gluten, and got her to move. I connected her with a faster EFT practitioner because she had a lot of emotional trauma around her fatigue and all that. So we did a lot of stuff with her, but at 2 and 4 week follow-up, she was already doing better. And even at 4 weeks, she was significantly better energy-wise, and the weight gain had finally stopped. And this was the first month that she could say that she had not gained weight, which is fantastic. And then my next patient, and I'm seeing her currently, she's an 18-year-old female who was presenting for weight management and sleep issues. And she had 3+ years of steady weight gain and sleep issues and on multiple medications, as you can see, and wasn't eating very well, effectively no exercise, BMI 33, other vitals were normal. And then her labs showed a suboptimal T4, low T3, and she was pre-diabetic, and no one had caught that on her. And all of the other labs were normal. So we changed her diet, worked on sleep hygiene, tapered off of trazodone, because I haven't seen that help actually many people. and she's feeling groggy and tired in the morning, which trazodone really contributes to that. So we did multiple different things, encouraged her to walk, and at 6-week follow-up, well, she was still gaining weight, so that was a little bit discouraging. She felt overall better, but still gaining weight. Even in 6 weeks, she had gained multiple pounds. So then I decided to do a salivary cortisol on her, and this is her result, which was completely shocking to me. And when I saw how high her morning cortisol was, I effectively redid her history. And her DHEA is high because she was on DHEA supplementation. So I redid her history, and we realized that she had mold exposure, and she was actually sleeping in a room, in a bedroom that was infested with mold. She was in a basement bedroom, and the basement had been flooded 2 years ago, and they knew there had been mold. They thought it had been well remediated, but obviously it wasn't. So we are actually actively in the process of working on this with this patient, and I'm trying to detox her and get mold toxins out of her. But this is actually, this case is to explain that if you find an abnormal result, well, dig into the history, because the history is going to tell you what's going on. So this patient, I'm going to retest after, either they're considering moving out of their home actually. So after she changes her environment, I'm going to redo a salivary cortisol to see how that curve, what that curve looks like, because I really feel that the mold exposure is what is causing a lot of her health issues and her weight gain and her high cortisol. So management right now, this is what we are currently doing. So hopefully she'll be following up probably actually in the next couple weeks. So I'm going to open this up to questions, and I know I'm a few minutes over, so I apologize for that, but I really wanted to go over the cases. So we're going to go over some questions.
Great. Thank you so much, Melanie. That was a terrific presentation, and we've already received some good feedback. I just want to remind everyone that the PowerPoint will be available on our website in PDF format next week. And since we did receive quite a few questions, I was going to start with one question. What's your opinion on intermittent fasting and its effect on the HPA axis?
I actually love it. I love intermittent fasting. And for people who aren't familiar with that, we're looking at either periods during the day, so a 12 to 14 hour period of fasting, or potentially even 24-hour fasting period during a week. So 1 or 2 days a week, there's a full 24-hour period of fasting. But most commonly, people fast for 12 to 14 hours. And I've actually had a lot of success at regulating blood sugars by doing that. So my patients measure fasting glucose in the morning, diabetic or not. I have people invest, and they invest in monitoring blood glucose monitor. And people who actually do intermittent fasting seem to have pretty consistently lower fasting glucose, and then just overall start sleeping better, and they just overall feel better. So I'm a huge fan. I'm a big believer. I really think there's something there that, and the nutritional therapist that I mentioned earlier, Alessandro Ferretti, has done actually a lot of studies on that. He also really embraces intermittent fasting, as many other of us out there. But I really like intermittent fasting. It's a great tool. It's underutilized, and it just gives the body a break. It's that big reset button. So when in doubt, if nothing else is working, have your patients fast, or at least do a period. So they stop eating at 7 at night, and then they don't eat until 7 the next morning. So that would be considered intermittent fasting, one approach to intermittent fasting. So great question. I really, really like that tool, actually. And it's not more pills, it's not more supplements, it's simply regulating food intake, and it's very effective.
Great. And another question came in as far as if you have a patient who's a severely stressed, high stress patient, when would you consider a moderate carbohydrate diet? What are sort of the circumstances where that would be appropriate?
So moderate carbohydrate diet versus low carb or very low carb?
Yeah.
Is there any clarification about that?
Yeah, that was my interpretation, versus low carb or ketogenic, yeah.
So it really depends on other risk factors. So if their fasting glucose is elevated, their fasting insulin is elevated, and or the A1C is elevated, I tend to go low carb right away. But I've also seen that very low carb, even sometimes moderate carb or lower carb, can be a little bit harsh, especially for patients who have more severe adrenal issues or HPA-Axis dysfunction. But I tend to try it. I really do try it, and I really hold their hands in terms of understanding that it is not low calorie, and they're going to be eating more fat. So it's really important to set them up for success and help them not be low calorie, because I think potentially why some patients have not done well historically with lower carb diet, patients with HPA-Axis dysfunction, is potentially because the lower carb was not done properly, and it wasn't just low carb, it was also low calorie, which that's a hormonal disaster, and it's incredibly stressful. So I actually tend to try almost right off the bat lower carb at or below 100 grams of net carbs, and I make sure they're eating good fats, lots of good fats. I tell them, when in doubt, add good fats. Have an avocado, have nuts and seeds, nut butters, add some olive oil to your food, have coconut oil. So I actually am pretty aggressive. I tend to go, especially if there's other risk factors like I mentioned, I'm going to go right away for low carb. I go right away for low carb. So I rarely consider moderate carb, but if I feel that they're really exhausted, they're depleted, and I'm suspecting significant HPA-Axis dysfunction, I'm really going to help them set themselves up for success with really convincing them to eat fat, because a lot of these people have not been eating a lot of good fats because it's not low in calories. So yeah, I don't do a lot of moderate carb, even in some of my exhausted patients. I tend to go for low carb right away, but I really support them in other ways. This is where start adaptogens right away if they're a good candidate for some B vitamins, which can be super helpful in so many patients. I'll do that. So I'm pretty aggressive. I start low carb very quickly, but I've seen a lot of success with that as well.
Great. And just one additional question. From a treatment standpoint, if somebody's been on a long-term low-calorie diet, what are some things you might consider to reset metabolism?
This is one of the trickiest things that I see in my practice, and overall also my colleagues specializing in weight management. This is the hardest thing we've seen. But things and supplement that help reset the leptin resistance that takes place after low-calorie diet have been pretty helpful. There's a supplement by Zymogen that's leptin manager that's pretty helpful. But the most success I've had is to consider short-term weight loss medications. That seems to have the fastest impact. And I usually, so if I see a patient, if I know a patient in their history, they've done a lot of low-calorie diets and yo-yo dieting, and I measure their fasting leptin and it's elevated, and by elevated I mean above 20, then I have the conversation very early on to consider the weight loss medication. So something like Contrave, I do phentermine in my practice as well, and to help set them up to success. And it's usually short term. They'll do it for 3 to 6 months. I've had a couple patients that have been on longer term, very low dose phentermine, but as a whole, help them start losing weight, because if they have leptin resistance, insulin resistance, they have thyroid issues, they've been doing yo-yo dieting, it's actually extremely hard naturally without support from medications or supplement. I found this very, very hard to reset. So I would love to be able to do a study about this or look into this more. And this is where us in this field really should collaborate and put our minds together as what else are we doing. But I've seen actually short-term medications be very, very helpful, and finally starting the weight loss. And when that starts, things start to regulate themselves. But the initial weight loss is extremely difficult in these patients. And I know you guys are seeing these patients, but have that conversation about adding potentially a medication, and at the very least, do supplements. And they're going to need a lot of support. The high dose chromium that I mentioned in there, berberine, and do leptin support like the leptin manager. So those are going to help set your patients up for success. But if after 1 or 2 months this is still not enough, then have that conversation about weight loss medications. There's not a lot of them out there, but Contrave is actually a great tool for a lot of the patients if they can tolerate Wellbutrin. But I tend to have that conversation. I'm pretty aggressive again when it comes to this, because I've seen multiple failures after 6-12 months of not being aggressive. So now I tend to be more aggressive from the beginning. And I have seen varying levels of success, but I have seen fairly good success, especially with phentermine, low dose phentermine. if a patient is a good candidate, they tolerate it. I've seen that do really, really good things actually for patients.
Great, thank you. And in the interest of time, we'll end our question and answer period there. But for additional educational materials, we'd like to encourage you to visit our website, www.gdx.net. On this site, you'll find sample reports, kit instructions, and other information for all our profiles. And after taking advantage of the materials found on our website, feel free to contact client services with your questions. You'll see a number on the slide for US and UK customer service. Additionally, please call client services if you need assistance in setting up a MyGDX account. We also offer complimentary appointments with our medical education specialists to answer questions related to our testing, including choosing the right test and reviewing patient test results. And finally, we'd like to encourage you to look for upcoming webinars on www.gdx.net. Next month, we will have Dr. Warren Brown presenting on specialty diagnostics for men's health, going beyond the PSA. And thanks again, Melanie, for a superb presentation.
Thank you so much for having me.
Have a great day.
Bye.